The earliest age a parent is recommended to bring their child to the dentist for their first checkup is after 1 year. This early exposure is to check on the status of the development of the oral cavity and also to make the child familiar with the dental setting and procedures. Dental anxiety is one of the most common fears and phobias. Given the high rate of dental phobia among children, it would be insightful to understand what causes these fears that may begin as a child and later develop into adult dental phobia. Many adults experienced painful and traumatic treatments that caused them to develop dental anxiety and avoid the dentist as they got older. It is important to empathize when it comes to dental anxiety. These fears that people experience are very real and even sometimes debilitating in their minds. The American Academy of Pediatric Dentistry recognizes that in providing oral health care for infants, children, adolescents, and persons with special healthcare needs, a continuum of both non-pharmacological and pharmacological behavior guidance techniques may be used by dental healthcare providers. Promoting a positive dental attitude, safety, and quality of care are most important. I'm going to address some of these methods of treating children in pediatric dentistry and why many have raised concerns. The goals of behavior guidance are to establish communication, alleviate fear and anxiety, deliver quality dental care, build a trusting relationship between dentist, child, and parent, and promote the child's positive attitude toward dental health and oral health care. Physical restraint has been a controversial topic among concerned parents and the dental community at large. The use of a papoose board is still common today, but more and more pediatric dentists are veering away from using this device. Dr. Joel Weaver, DDS, PhD, questions why physical restraint is still even acceptable for dentistry if it has the potential for psychological harm. Deep sedation techniques and restraining devices such as the papoose board are not acceptable in other countries, including the United Kingdom. By following the guidelines of the American Academy of Pediatric Dentistry, dentists should practice safe behavioral management techniques as advised. The American Academy of Pediatric Dentistry's indications for physical restraint include the following. 1. The patient requires immediate diagnosis and/or limited treatment and cannot cooperate because of lack of maturity or mental or physical disability. 2. The safety of the patient, staff, dentist, or parent would be at risk without restraint. 3. The sedated patient requires limited stabilization to help decrease untoward movement. The APPD contraindications for physical restraint include 1. The non-sedated patient is cooperative. 2. The patient cannot be immobilized safely because of associated medical or physical conditions. 3. The non-sedated patient with non-emergent treatment requires lengthy appointments. And 4. The patient has experienced previous physical or psychological trauma from physical restraint, unless no other alternatives are available. Many pediatric dentists follow these guidelines accordingly and have had no complaints from parents or children. Here are the instructions for strapping a child onto an Olympic papoose board provided by Quick Medical Supplies. Many dentists administer nitrous oxide once the child has been strapped to the papoose board.
The reason for using nitrous oxide, or laughing gas, is for its calming effect. Since nitrous oxide doesn't numb the teeth, anesthetic is still necessary. It just has the nice effect of making a person more relaxed. You breathe nitrous oxide in through a small mask that covers your nose. It takes just a few minutes for you to notice the effects. People most often describe the feeling as being relaxed, unconcerned, happy, slightly numb, and disconnected from what's happening around them. We can adjust the dosage of the nitrous oxide gas to fit your needs. You can also control its effects by your breathing. The more you breathe deeply through your nose, the more you'll feel its effects. There are no long-lasting effects. We won't use nitrous oxide if you have an inner ear infection or symptoms of asthma. Let us know if you'd like to try nitrous oxide to feel more relaxed during your dental appointment.
Here is a dental practice in Georgia, which uses a combination IV sedation under a team of anesthesiologists. Keep in mind that most dental practices can't afford a team of anesthesiologists. Their staff here includes board-certified anesthesiologists, certified registered nurse anesthetists, and physician anesthesia assistants to provide an integrated team of care members. Here they use the papoose board and administer Versed orally in addition to IV sedation. The sedative Versed prior to IV insertion in combination with nitrous oxygen allows for a pain-free treatment. A consultation between the parents and dentist is important, and this doctor-parent-patient communication is crucial. Delta Dental conducted a survey among 926 primary caregivers of children aged 0 to 11, which indicated that 30% of the children were afraid to visit the dentist. That number rose to 40% among children whose parents were afraid of dental visits. Some reasons that children fear visiting the dentist are because of their sensitive teeth, accounting for 17%, the noises and smells accounting for 11%, drills and other dental equipment for 10%, and 9% feared the injections and needles. It is no wonder that the use of nitrous and other sedatives have become extremely popular among dentists to alleviate these children's fears. Nitrous oxide inhalation is the preferred technique for pharmacological management of anxious pediatric dental patients. Nitrous inhalation is a cost-effective alternative to general anesthesia. Some complications that can arise include respiratory depression, nausea, hypoxia, hyperactivity, and unintentional loss of consciousness. After interviewing multiple dentists, their chief complaint for using nitrous was that the children became nauseous and would throw up while receiving treatment in the chair. Nitrous is administered in a titrated dose in oxygen. The standard delivery system of nitrous prevents nitrous oxide gas concentrations in excess of 70%, with an assured minimum oxygen concentration of 30%.
When choosing the right sedative for your child, choose an expert you can trust. Dr. Shilpa tells us why.
The most milder form of sedation is known as the nitrous oxide sedation, which is also called as the laughing gas. It is the most mildest and the most safest form of sedation. During that sedation, the child is fully conscious, is able to respond to the commands, and can communicate with the dentist. And it's really very safe. The child breathes in through a mask, inhales it. It kicks in very soon, in a couple of minutes, and the child is very relaxed. They may have some tingling sensation in their hands. They feel like they may feel a little bit like a floating effect, or else a sense of good feeling or euphoria. So which makes the child more relaxed, so they can go through the procedure very easy.
Calculating the correct dosage of sedative for children is more difficult because there is greater variation among size, weight, and how their little bodies handle and react to the drug. Many parents make videos of their kids and even teenagers waking up from dental procedures after receiving heavy sedation and find it entertaining to put these on YouTube. This action is ethically questionable on part of the parents. But are these doctors taking the necessary safety precautions, or are the children being drugged too much? Almost everyone has seen the viral video, David After the Dentist. Besides being extremely confused, David almost appears upset that he is not in control of the funny feeling he has and wonders if it'll last forever.
Surgery.
Yeah, I know. How did it go?
I didn't feel anything.
Yeah.
I feel funny.
Kind of felt good, didn't it?
Is this real life?
Yeah, this is real life.
Okay, now I have 2 fingers.
Good.
4 fingers.
4 fingers? No, Don't put it in your mouth. Okay? You feel good?
I can't see anything.
Yes, you can. Stay in your seat.
I don't feel tired.
You don't? No?
Do I have stitches?
Uh-huh.
Do I have stitches
Yes.
on my teeth?
Yeah. Don't touch it. Don't.
Why can't I touch it?
Because it'll mess up the stitches.
You have 4 eyes.
Yeah.
I feel funny. Why is this happening to me?
It's okay, bud. It's just from the medicine. Okay?
Is this going to be forever?
No. No, it won't be forever.
Oh.
The sad reality is many children are being mistreated by dentists. The hand-over-mouth technique was used by pediatric dentists for a long time and was part of the dental curriculum until the late 1980s. When used effectively, it is quick and harmless, but when a dentist is struggling and uses such technique out of desperation, it quickly turns ugly. Major arguments against hand-over-mouth technique were that it is unethical and immoral, and inflicts long-term psychological harm on some children and can create dental phobics. The major group addressing hand-over-mouth technique was the Committee on Child Abuse and Neglect. If this form of restraint is outdated and unacceptable, are we evolving toward eradication of the use of the papoose board as well? Here you can see a little boy named Calvin being strapped into a papoose board, and he is repeatedly screaming and crying. When asked what he is saying, the mother tells them that he is yelling, "Too tight."
What's your brother saying?
Oh, Calvin.
What is he saying?
Oh, he says too tight.
Oh, too tight. No. If you don't have Calvin, if you're not going to move too much.
Children are reporting to their parents what is happening to them, and parents are finally speaking up. Multiple investigations have been carried out against Small Smiles dental practices. There are around 70 clinics scattered around the country delivering dental care to 500,000 children annually. One of their policies prohibits parents from being with their children in the treatment area. These clinics treat low-income children on Medicaid, so many of them require an excessive amount of treatment since they have possibly never seen a dentist. A former worker reports that they were performing unnecessary baby root canals for bonus money. Medicaid reimbursements for routine treatments like cavities are low, but the clinic would receive $214 in Medicaid funding for each baby root canal. Small Smiles dentist argued that it is not cost-effective to not restrain the child. It speeds up the process and allows for a faster flow of patients. Many of these dental centers have been investigated for committing Medicaid fraud. This is completely unethical to use children to make a profit at the expense of their suffering. These dentists are misusing devices that were created to protect and provide stabilization instead as tools of torture. To eliminate the need for restraint, a couple changes need to occur. Firstly, insurance companies and government-sponsored healthcare programs should cover deep sedation and general anesthesia for dentistry, as other medical procedures such as tonsillectomy are currently covered. This way, all children would have acceptable pain-free dental treatment, and possibly not even remember it. Also, the need for mobile dentist anesthesiologists will keep increasing to provide safe and cost-effective in-office anesthesia services for patients who need it. With a shortage of these dentist anesthesiologists, access to acceptable care will be limited. Unless changes are made, traumatized children will continue to grow up into adult dentophobics who avoid receiving regular treatment and care, which will ultimately cause them more pain in the long run from neglecting their oral health. We don't want dentists to be continually associated with pain, and as many dentists in the New Orleans area have agreed, papoose boards are necessary in certain cases, but tighter regulations need to be enforced.